So here you see the base of the skull, and we have already made it and studied it. And here we have placed the mandible is there. So we'll take off the mandible, and you can see the hyoid also, two arched bone placed below the base of skull. We'll take both of these off. So I take off the mandible, I touch this, the mandible is out, and then I touch the hyoid, and the hyoid is out. Then from this base of the skull, we will hang the pharynx first, right? So we'll do this board, and we will quickly revise. This is the hard palate that we have seen. We'll just make a small dot to show you the hard palate. Consisting of the maxilla, right and left inferior surface of maxilla in the anterior part, and the horizontal part of the palatine bone in the posterior part. This is the palatine ridge, and this palate is basically, this hard palate is separating the space above it, which is the nose, and below it, which is the mouth. It has a nasopalatine foramen anteriorly and greater and lesser palatine foramen posteriorly. Greater and lesser palatine foramen in this region. Now, there's a cruciate fissure which divides these four bones, and this is the palatine ridge. So from the palatine ridge, we'll first place the soft palate. So the soft palate, this is the greater vingus sphenoid. The greater vingus sphenoid. And these are the two pterygoid processes hanging from this greater vingus sphenoid. This is the medial pterygoid plate, and this looks to be the lateral pterygoid plate. Now from the medial pterygoid plate, from the lateral side of the medial pterygoid plate, there arises a muscle which is called as the tensor villi palati. It winds round the pterygoid humulus, and it becomes an aponeurosis which is attached to the palatine ridge, or the posterior part of this. On both sides you have this tensor villi palati, and this aponeurosis forms the base of the soft palate. So the first thing we have placed is the tensor villi palati. Now this palate, on this aponeurosis is attached a palatoglossus which will go to the tongue, and the palatopharyngeus which will go to the pharynx. Alright. Then if we place we'll place a part of the mandible here. We'll place it in different color so that you can see. So if this is the mandible, just place the portion of it here. Then there's a ligament. Supposing this is the mandible, then there's a ligament which connects the pterygoid process to this mandible. From this pharyngeal tubercle, there descends a raphe. So from the pterygoid plate, medial pterygoid plate, pterygomandibular ligament and the mandible, there arises a muscle, and this muscle comes and gets attached to this pharyngeal raphe. This is the pharyngeal raphe. Same way, the other portion of the muscle would be like this, and thus you will have a space between these muscles of the two sides, and these muscles are called as constrictor muscles. So if we want to show it in the lateral view, this is the mastoid process, this is the acoustic meatus, this is the zygomatic arch and the zygomatic bone, this is the orbit, this is the nose, this is the maxilla. Here will be the pterygoid plates, and here will be the mandible, and from this medial pterygoid plate there will be a ligament, pterygomandibular ligament, and from this pterygomandibular ligament there will be a muscle which will go anterior and form the lateral wall of the mouth, that means the cheek. This muscle is called as buccinator. So the muscle which will go in front of the pterygomandibular ligament outside the mandible will form the cheek here, and the buccinator of the two sides will meet and form the lips. So the pterygomandibular ligament, anterior side buccinator and posterior side constrictor. And there are three constrictors, the superior, inferior and middle constrictor. Since we have made this much, let me convert to the lateral view and move forwards. So we'll make it the lateral view. Here you can see the lateral view, and in this lateral view, which we should move this side so that we can see this, we have placed the mandible. The mandible here, which is housing these teeth, and we have placed a pterygomandibular ligament connecting the medial pterygoid plate to the mandible. This is the pterygomandibular ligament. Then we have put the buccinator muscle anterior to it, forming the cheek and going to form the lips. The orbicularis oris. Orbicularis means surrounding the lips. So the buccinator fuses into the orbicularis, means around, oris means mouth. Then from the middle of the base of the pharyngeal occipital bone, we have been able to drop a raphe, which is the pharyngeal raphe, and we have been able to place the superior constrictor like this. Above the superior border of the superior constrictor and covering all this space is a membrane which is called as pharyngobasilar membrane, because it connects the pharynx to the basilar occiput bone, and that's the space is closed. Space inside the constrictor is closed. Below this, we'll place the hyoid bone, which was here, and from the hyoid we'll take out the second constrictor, which is attached to the pharyngeal raphe, which is the middle constrictor. Below that, there will be the thyroid bone, thyroid cartilage, and from it and the cricoid cartilage will arise the inferior constrictor. Thus, the inferior, the middle, and the superior constrictors form a space within the constrictors which is behind the nose, which is the nasopharynx, or behind the mouth, which is the oropharynx, and behind the larynx, because in the thyroid cartilage lies the larynx, hyoid and thyroid lie the larynx, so the laryngopharynx. And then the laryngopharynx behind the cricoid goes into the, so this bone after the thyroid cartilage, there's the cricoid cartilage. Now the cricoid cartilage is a posterior border. So this laryngopharynx will go into the esophagus, and this will go into the from the cricoid will go into the trachea. So finally the pharynx will become trachea and esophagus. Right, and all these are because of the constrictors which are attached to the this is the inferior constrictor, this is the cricopharyngeus muscle, and this will lead to the esophagus, and this will, from within the cricoid, there will be the trachea. So this is the viscera of the neck, which is actually hanging from the base of the skull. From the occipital condyle, there will be this cervical spine, and the cervical spine will have extensors, will have flexors, will have right and left lateral flexors, and may have rotators, right and left rotators. So the muscles that attach the skull to the cervical spine are able to flex, extend, laterally flex and rotate the cervical spine. Besides this, some muscles arise from the spine and the skull which are attached to the pectoral girdle, and so they are able to move the scapula over the thorax as well. Now, so this will be the nose, these will be the lips, this will be the chin, and here we are going to the anterior portion of the spine. And on this side is the neck, and this is the forehead, and here will be the eye. So I hope you have been able to understand the importance of the pterygomandibular ligament and how this pterygomandibular ligament forms the superior constrictor and the buccinator, forming the wall of the mouth as well as giving rise to the pharynx. And between the vertebra and the pharynx lies the retropharyngeal space. So now we'll draw a diagram from the front. We take this off, which will be the oral cavity. So let us draw the oral cavity. These are the lips. Let us say that these are the lips of an open mouth. On the base of the lips, you see the tongue. And you can see behind this the soft palate and the uvula. So we'll make that soft palate much clearer for you. We'll make the superior constrictor. We have made the tensor villi palati coming from the medial part of the medial pterygoid plate and becoming a aponeurosis like this from both sides. From the tip of this palatine aponeurosis, so this is a soft palate aponeurosis, we have put the musculus uvula, which you see hanging. Now there is a muscle which elevates the soft palate, that is called as the levator palati, and there's a muscle that arises from the soft palate and goes into the tongue. So it lifts up the tongue, that is called the palatoglossus, and there's a muscle which goes and meets the superior constrictor, which is called as the palatopharyngeus. It will go and get inserted into the thyroid cartilage. So this palatopharyngeus will lift up the thyroid cartilage. So between the palatoglossus and the palatopharyngeus, you have the tonsil. So here you see in the mouth you will see the palatoglossus and the palatopharyngeus, and you'll see the tonsil in between. So this is the tonsillar fossa. Now from this larynx, going behind the tongue is what is called as the epiglottis. And if this is the epiglottis and this is the tongue, then this epiglottis is held from the tongue by glossoepiglottic folds, the right and the left one and the median one. So you have a fold here, the tongue holding the epiglottis, and there's a median one, and the space between the epiglottis and the tongue is called as vallicula. So we have been able. Then there's one very important thing which you must understand, and that is that this levator palati will lift off the palate. Okay. So when the levator palati lifts off the palate, the inner fibers of the superior constrictor contract and they form a ridge. They form a ridge like this, against which the soft palate will close, and thus the nose will close. So if we want to show you this, here is the hard palate, here is the soft palate, here is the soft palate, here is the pharyngeal raphe, and here is the superior constrictor of both sides. So what will happen, that there will be a ridge like this, against which the soft palate, as it rises, it will close against this ridge. This ridge is called as the passavant's ridge. So we have been able to make the upper portions of the mouth as they are linked to the base of the skull. And now we have to only place the mandible and ensure how that mandible moves. So we go ahead. The first thing to see is how the tongue moves. So if this is the tongue, it is attached to the mandible by, and here we'll make the mandible here, it's coming from both sides. It is attached to the mandible by a muscle called as genioglossus. So genioglossus would pull it forward. Then there's a muscle coming from the styloid process, which is here. Styloglossus will pull this tongue backwards. All right, palatoglossus, the soft palate up and tongue here. So palatoglossus will pull the tongue up. And there's a hyoid bone below. There's a hyoid bone below here. That hyoglossus will pull the tongue down. So genioglossus forwards, styloglossus backwards, palatoglossus upwards, and hyoglossus downwards. So we've been able to place the tongue in the mouth, and we have been able to see how the tongue can be pulled forward, backward, up and down. Okay. After this, we move on to the next component, and here what we'll do is we will do away with this picture. We'll go to the overview and we'll draw this. We'll use this base now. So the from this hyoid bone to the middle of the mandible is a raphe, is a center. from the mandible, there's an oblique line which goes from the foramen on the ramus of the mandible. That foramen carries the inferior alveolar nerve, which is the nerve supplied to the mandible. So there will be a foramen here and there will be a nerve entering that foramen. From that there is an oblique line going like this, and from these two sides oblique lines comes a muscle which is the mylohyoid. So this is the mylohyoid muscle. This muscle will form the floor of the mouth. The submandibular gland supposing this is the mylohyoid muscle from the side coming like this to the hyoid bone, there will be a gland, submandibular gland, which will have a deep part and a superficial part, and this gland would be basically forcepping the posterior edge of the mylohyoid muscle. Now this submandibular gland has a superficial part, has a deep part. Superficial part is superficial to the mylohyoid, deep part is this, and it's like a forceps that it holds the posterior edge of the mylohyoid muscle. So we make that gland here. It's forcepping it. Now what happens that the facial artery comes like this, winds round the posterior pole of the submandibular, then winds round the lower border of the mandible, and then goes into the face, becomes superficial. So this is the course of the facial artery which is arising from the external carotid. It winds round the posterior pole of the submandibular gland, and then the submandibular gland has a duct and it opens into the base of the tongue. So submandibular and the sublingual glands are the glands that put saliva into the mouth between the mandible and the tongue. And parotid gland pierces the cheek and puts saliva in the mouth between the mandible and the cheek. That means outside the mandible. So you have now understood this, that the facial artery would come here, wind round it, come here, and then wind round it and go into the face. Okay. So you've placed the mylohyoid. Now, from the medial part of the mastoid arises the digastric muscle. This digastric muscle would form a tendon near the hyoid, and this digastric muscle would finally go anteriorly like this, and from the digastric muscle of both sides, this is the anterior one this side and this is the posterior one, you will have a submandibular fossa and a submental fossa in this. So this is the submandibular fossa and this is the submental fossa. Submental fossa is one and submandibular fossa is on the right and the left side. And this triangle formed between the digastric muscle and the mandible is called as the digastric triangle. Then you have, we'll simply place the pharyngeal raphe here, and from the pterygomandibular ligament we'll place the superior constrictor from both the sides. If it is coming from the hyoid, it is the middle constrictor. If it is coming from the thyroid cartilage, it is the inferior constrictor. So this is the floor of the mouth and we have been able to place the tongue in it, and therefore this structure is complete, except that now we have to arrange how to open and close the jaw and how to move the lower jaw sideways. So a muscle arising from the pterygoid plate and attached on the medial side of the ramus is the medial pterygoid. And muscle arising from the zygomatic arch and attached to the medial lateral side of the ramus is called as the masseter. So if the masseter of this side and the medial pterygoid of the opposite side will contract, the jaw will move this way. And if the masseter of this side and the medial pterygoid of this side will contract, the jaw will move this side. Therefore, we have been able to place the sideways movement of the jaw so that grinding becomes possible. Now we'll get rid of this diagram and put this jaw like this laterally and place a muscle that will open and close it. So a muscle arising from the infratemporal fossa, the horizontal portion of the greater wing of sphenoid, this one, and from the lateral pterygoid plate, which will be behind this ramus, and this muscle coming and getting inserted. It has got two heads, from the infratemporal fossa and from the lateral pterygoid plate, coming and getting inserted into the neck of the mandible is called as lateral pterygoid, and it will pull this forward so that the jaw opens. Pull this portion forward so that the jaw will open. A question here is that the examiner may make you say that it's the gravity that opens the jaw. That means if you go into space, you will not be able to open the jaw. Not true. So it's the lateral pterygoid that opens the jaw, and the muscle that closes it, this is the zygomatic arch. This is the zygomatic arch, and the muscle passes under the zygomatic arch and then winds round it like this. That is the inferior temporal line. This muscle is the temporalis, and this is the major muscle that closes the jaw. So the temporalis closes it, the lateral pterygoid opens it, the medial pterygoid and the masseter move it from side to side, so that now the mastication becomes possible. That means the food is pushed by the tongue between the cheek and the mandible, which is called as the vestibule, and there it's mixed in the saliva by the parotid gland, and by the buccinator it is pushed back. And while this is happening, the teeth are moving up and down. The lower jaw is moving up and down by lateral pterygoid and temporalis, and is also moving side to side by masseter and medial pterygoid, so that the food is mixed with saliva and converted into a bolus. So this is important, and we'll be able to place the masseter from the zygomatic arch to the this. This is the masseter. Okay, now this temporomandibular joint has got a meniscus, and this temporomandibular joint can open, can go close, and can also move from side to side. So it is a condyloid joint. Behind this you see the external acoustic meatus. You see the styloid process. This styloid process gives a styloglossus muscle going to the tongue, a styloglossus, a stylohyoid, and the most important is the stylopharyngeus, which goes into the thyroid cartilage. So the stylopharyngeus passes between the middle, here will be the middle constrictor, and the inferior constrictor. Here will be the inferior constrictor, and attaches to the thyroid cartilage. Now the stylopharyngeus has a nerve which winds round it, which is the glossopharyngeal nerve, and this glossopharyngeal nerve actually makes the stylopharyngeus contract, so that the full thyroid cartilage would rise up. The thyroid, the hyoid will also rise up, and the epiglottis, if this is the hyoid and it is rising up, the epiglottis will close over the larynx. So the tongue has risen up by the palatoglossus. It has gone against the hard palate. It has gone against the hard palate. So it is squeezing the food. It is squeezing the food on top of the epiglottis. Here are the vallicula. So as the food is pushed onto the epiglottis and this root of the epiglottis is pushed up, the epiglottis closes and prevents the food from sliding into the larynx or the trachea. And therefore the food will fall back into the laryngopharynx, and then from there it will go into the esophagus. So when you want to deglutation, then the tongue must move against the palate, squeezing the food from the mouth into its posterior aspect, and there as the tongue moves up, the stylopharyngeus supplied by the glossopharyngeal would lift up the thyroid cartilage and the hyoid and the epiglottis, and as the root rises, the epiglottis will close like a trap door, and the food will actually slide into the laryngopharynx and not into larynx. Also, simultaneously, the levator palati will move up, and the superior constrictor will form a passavant's ridge against which the palate will close, and the food will not be able to go through the nose as well. So pushing the food from the mouth into the laryngopharynx and esophagus, and not into the larynx, protected by the epiglottis and the stylopharyngeus, and the nose, protected by the levator palati and the passavant's ridge, is the process of deglutation. So mastication and deglutation and the muscles that produce it. Then we move further, and now we have a line. So this is the line which is called the inferior temporal line, and this gives rise to the temporalis. There is a superior line also, superior temporal line. And the superior temporal line, you can see it's coming up to here, and there is this suture, and there is this suture. So this is the suture of the parietal bone. This is the parietal bone. So a muscle will arise from here, which is the occipitalis, and will insert here, which is the frontalis. So it is the occipitofrontalis, and in between this muscle will have an epineurosis, which is called as the galea epineurotica, and that epineurosis will be attached to this superior temporal line. Now, just anterior to the lobule of the ear. So this is the lobule of the ear. Anterior to it, if you draw a cornal plane, and you insert the skeletal traction on this, then this plane is the plane which goes through the flexion extension axis of the atlanto-occipital joint. As it goes through the axis, any skeletal traction in this plane between these two, between the temporalis and occipitofrontalis, will neither produce flexion nor produce extension. So this is the point between the superior and inferior temporal lines, between the temporalis and occipitofrontalis, just in front of the ear, which is the correct point to put a skeletal traction which will pull the skull but will neither produce flexion or extension, as this is the plane that passes through the flexion extension axis of the atlanto-occipital joint. So this much. Here you have the inferior orbital fissure through which emerges the inferior orbital nerve, and here you have the external occipital protuberance, and from this you have three lines. One is the highest nuchal line, from which arises this occipitalis. Then you have a superior nuchal line going up to the mastoid process. From the medial part of this superior nuchal line arises the trapezius, and from the lateral part, the occipital portion of the sternocleidomastoid. So this is the sternocleidomastoid, and this is the apex of the posterior triangle, because the posterior triangle is bounded by the anterior border of trapezius, posterior border of sternomastoid, and middle third of clavicle. The apex is the middle of the superior nuchal line, and then you have the highest inferior nuchal line, which is a very important line if you want to understand the boundaries of the suboccipital triangle. So these are the lines here, and what I want to tell you is that the digastric muscle, arises from the inner part of the mastoid, goes up to the hyoid, lesser cornu of the hyoid, and would go like this. And this triangle is called as the digastric triangle or the submandibular fossa. From the inner side of this line would be the mylohyoid muscle, which will be going on to the hyoid like this. Then there will be a hyoglossus muscle, which will be going from the hyoid. We'll make it in a different color. It will be going into the tongue. So it will be going into the tongue and pulling the tongue down. The palatoglossus will be pulling it up. The styloglossus will be pulling it back, and the genioglossus will be pulling it in front. And the longitudinal fibers, transverse fibers, and superoinferior fibers will be able to fold the tongue in any manner. So this is the digastric muscle, and from outside I told you is the sternomastoid. And I told you that this is the suprameatal triangle of McEwen, which overlies the air cell, the biggest air cell of the mastoid process, which is called as the mastoid antrum. The mastoid antrum is behind the middle ear. So if this is the middle ear, this middle ear has opening into the mastoid antrum, which is called as the editus ad antrum. The mastoid antrum superiorly would cause a temporal lobe abscess through the tegmen tympani. Inferiorly, the abscess in the mastoid antrum can go into the sternomastoid or into the digastric, and this is called as the Bezold's abscess. Now the junction of this frontal bone, you can see the suture here, of the greater wing of sphenoid, of the squamous temporal bone, and of the parietal bone is called as pterion. And it is this pterion that you open up, and you will get the middle meningeal artery, and you will be able to drain an extradural hematoma, and you will be able to plug the middle meningeal artery as it enters the cranium through the foramen spinosum. Now this styloid process, besides having the styloglossus, stylohyoid, stylopharyngeus muscle, also has a stylomandibular ligament and a stylohyoid ligament. So there are two ligaments from the styloid process, stylohyoid and stylomandibular. So I hope we have been able to revise the norma lateralis to quite a good degree.